Bismillahirrahmanirrahim. Hi everyone. So in this second video, we're going to talk about assessing serum osmolality to look for pseudohyponatremia and for hyperglycemic hyponatremia. So this is a quiz from the last video. If you haven't read it before, you can pause the video, go over it, read it, and try to answer, and then we're going to discuss the answer in the next slide. Okay, so this is a case of ODS or osmotic demyelination syndrome despite appropriate rate of correction of hyponatremia, right? So remember in the last video we talked about some risk factors for a patient who can develop ODS despite appropriate correction, and these are patient with history of alcohol, patient with history of severe liver disease, patient with severe hyponatremia at the beginning of therapy, patient on chronic use of diuretics, especially if they're hypokalemic, and patient with malnutrition. These patients are really high risk, and you need to be very careful with correcting hyponatremia. So this 55-year-old male, he has history of alcohol, he has volemic hyponatremia, seems to be chronic, and then it looks like he was appropriately corrected, as we're going to talk about management in the coming videos. Usually you don't want to go over 8 to 10 milliequivalent per day, or up to 18 for 8 hours. It seems like this did not happen here, but despite that, the patient has clinical features and MRI features of ODS. So this is actually kind of a case report, and again, this is a non-entity. Fortunately, it's a rare entity, but it still it does happen, so be careful and be aware of it. Okay, so why do we order measured osmolality first? Usually in my patients with hyponatremia, especially if the cause is not very clear, first I would like to get a measured osmolality first. Now, a lot of the electronic health records and in this section of the lab, they actually give you the calculated osmolality. So the calculated osmolality is based on the sodium that they have in the system. So this might not be correct if the patient is having one of the conditions we're going to talk about. So you want to send for specific measured osmolality test to kind of measure a true serum sodium. So basically what happens is true hyponatremia, if you can imagine, is supposed to be associated with a low measured osmolality, right? Because sodium is the main cation in the extracellular fluid. So if a patient is having hyponatremia, the measured osmolality should also be low. If there is any discrepancy between the two, the patient is having hyponatremia, but the measured osmolality that you tested is not low, it's either normal or even high. So this is indicated that other pathology that's happening. Now, pseudohyponatremia is this. If you want to be more strict, it's usually applied to the fact that the measured osmolality is normal. If the measured osmolality is high, this is called hyperosmolar hyponatremia. But if you want to be to just go with the actual term that pseudohyponatremia means, it's not true hyponatremia, meaning the measured osmolality is not low, then technically this applies to both hyper and normal osmolar hyponatremia. But strictly speaking, pseudohyponatremia is when there is hyponatremia in the lab sodium, but there is no the measured osmolality is normal. So why does this happen? So basically, in most of the lab, maybe not all, what they do, if to kind of decrease the volume of blood they need for analysis, they take a small sample. And as you know, most of the time the water phase is about more than 90% of the solid phase, right, in the normal constituent of plasma. So this is a venous sample of the patient that does not have pseudohyponatremia. So they add standard volume of diluent. That's kind of the way the lab usually process the samples when they want to measure electrolytes. So this will lead to dilution of the sample, and then they can take multiple part of the blood for analysis. So this is kind of one way that the lab, most of the time, in my understanding, that's how they do it. So if in patient with increased lipids or increased proteins, like in patients with multiple myeloma, these are the conditions that usually associated with pseudohyponatremia. So what happened is, because of the presence of these high lipids or high proteins, the solid phase is actually much higher compared to the normal, let's say, I don't know, 15, 20%, 25%, depending on the severity of the condition. And that will lead to decrease in the water phase. So this is more particles are the sodium. So if you can imagine, the particles in sodium here is less than the particles of sodium here because of the increased solid phase, because of these conditions. So the lab will still do the same thing. They will still add a standard volume of diluent to the sample to do the same thing, to measure the sodium. So that will lead to even more or less sodium particles. So as you can see here, the concentration of sodium will be really low, seemingly, compared to if the patient does not have increased solid phase because of hyperlipidemia or hypoparaproteinemia or hyperproteinemia or hyperproteinemia. So, and that's happened because basically in each situation, the lab will still add the standard volume of diluent to the sample. So this is theoretically, why some patient with severe hyperlipidemia, hypercholesterolemia, hypertriglyceridemia, or patient with hyperparaproteinemia, like in multiple myeloma, why they might have a false low sodium, despite the fact that the measured sodium might not be low. So if you're suspecting that, then you can ask the lab to see if they do the flame photometric measurement. This is basically more commonly associated with pseudohyponatremia if the lab does a measurement of sodium with this specific maneuver compared to ion selective electrode method. This is basically like a specific method that the lab will know. This kind of use some language, maybe the lab can understand what you're talking about. When do you suspect pseudohyponatremia? If hyponatremia is resistant to treatment, or if hyponatremia is unexpected in a patient who is totally asymptomatic, meaning there's it doesn't make sense. There's something going on with this patient hyponatremia that you're not sure. So if you don't want to miss pseudohyponatremia, one thing you can do is to think about pseudohyponatremia and ask the lab if this is how they measure the serum osmolality. One other maneuver that you can do instead of measuring the osmolality separately is to actually order the electrolytes in the ABG. So the ABG analyzer, they usually do not use the dilution method, so it will be more accurate. So this is one test you can do quickly if you're still suspecting pseudohyponatremia and you want to know if the actual serum sodium is low or not. Okay, so for hyperglycemic hyponatremia, which is the other category, when you're not talking about osmolar hyponatremia, because we just talked about osmolar hyponatremia. Here, this is the cause of hyperosmolar hyponatremia, meaning the measured osmolality is actually high instead of being low, like in true hyponatremia. Some people call this translocational hyponatremia because of the movement of water. So basically, what happens is when there is osmotically active substances like glucose, mannitol, glycine, or maltose, what happens is water will move across its concentration gradient to the intravascular space, and this will lead to dilution of sodium. So the mean sodium will be low, although the numbers of sodium particles might not change, but this is because of the translocation of water, because of the increased osmotically active substances that led to hyponatremia despite the osmolality being high. So the most common cause that you're going to see is hyperglycemia, right? So for each 100 milligram per deciliter increase of glucose above the normal level of 100, this will lead to decreasing the serum sodium concentration by 1.6. So you can do the math, or you can just use an online calculator. It's much simpler and quicker. It's widely available now. So again, this will be the most common cause that you will see in patient with hyperosmolar hyponatremia. So if the patient is hyponatremic and the glucose is really high, you want to do the correction before you assume that the patient is having severe hyponatremia. And this is most common, as you know, is from DKA, or in patient with hyperosmolar hyperglycemia as a complication of diabetes. And then also in the ICU, sometimes they use mannitol. Mannitol also can increase osmolality. It's an osmotically active substance. Glycine, as we mentioned, it can happen because of increased absorption of irrigation fluids during urological or gynecological surgery. So if you have a patient with urological or gynecological surgery and they have developed hyponatremia after surgery, think about glycine. I don't know how often now they use this irrigation fluid that contain glycine in currently, but this is well known in the literature. Use of maltose and maltose intoxication. If the patient had IVIG therapy, especially if there are multiple therapy and they have kidney dysfunction, that might lead to accumulation of maltose, and maltose can be osmotically active and can lead to hyperosmolar hyponatremia. Now, urea and alcohol, they also increase osmolality, but they're really readily across the cell membranes, and they might not have the same effect as these substances. So you just keep in mind that if you have a patient with very high urea or ethylene glycol or any of the other alcohols, this might affect the level of the sodium to some extent. But again, these are more common, and among those, glucose is much more common, and I'm sure many of you have seen it in clinical practice. Okay, by this we finished talking about the conditions associated with false or pseudohyponatremia and the hyperglycemic hyponatremia. Then we're going to talk about the true hyponatremia and its classic classification of hypervolemic, hypovolemic, and isovolemic euvolemic hyponatremia. So this is just the question or quiz or a clinical vignette, so you can think about it, and then we'll talk about this quiz at the beginning of the next video. All right, thank you.